we enter our new normal going forward with this series. So I'm extremely delighted to welcome you all here in person and online to our NAO lecture. And Professor Steve Thomas is joining us in person in Toronto. He's coming to us from Trinity College Dublin, where he's a professor of health policy and leads a program of work to look at health systems resilience and reform in Ireland, with many implications and lessons learned for Canada and other high-income countries. And so it's my great pleasure to introduce Steve here today, who's spending 2 months with us in Toronto on part of his research leave. So he's got a few more weeks left in Toronto, should this spark any ideas or questions, and then he may be able to actually meet you or chat with you after today while he's still in Toronto. So I'm going to start this series pretty quickly. We only have an hour, but the NAO lecture series will be available and posted on our website. And we look forward to welcoming you to future series. I should have introduced myself. I should have started with that, but I see so many familiar faces here. But I'm Sarah Allen. I'm Associate Professor at the Institute for Health Policy Management and Evaluation at the University of Toronto, and the Director of the North American Observatory on Health Systems and Policies. And so without further ado, I'll turn it over to my esteemed colleague, Professor Steve Thomas, and I'll minimize this so you can have full view.
Great.
And I'll moderate the discussion and Q&A after your lecture.
Thank you so much, Sarah. Thank you. And it's lovely to be here. Thank you so much to the North American Observatory and the Institute for having me here. And online also, thank you to my colleagues who couldn't be here, and particularly to Greg. So a big shout out. And I hope your ankle is getting better, Greg. I'm sorry about the walk. But we'll get you a t-shirt, even though you won't get to finish it up. Okay. Participant request that live transcription be enabled for the meeting. Fine by me, if you can follow my accent. That would be a challenge. The rest of it. Okay, so so what I'm going to be talking about today is revitalizing. Do I need to click that? Revitalizing healthcare reform through the pandemic, the further adventures of Sláintecare. And the reason why I'm saying further adventures is because last time I was here, I actually talked about Sláintecare and its origins, and we'll be seeing how it's got on. And also last time I came here, it was March, and it was minus 15 degrees. And I wore my PJs underneath my suit. Okay. So no PJs today. Okay, no PJs. We're good today. This is good. This is acceptable. I'm delighted about it. But you may not know, actually, just recently, Sláintecare had its 5th birthday. So happy birthday to Sláintecare. So there we go. 5th birthday, 5 years on. My goodness, how. So we'll be seeing how Sláintecare has fared in that 5 years and what are the prospects for it as we go through. Right, okay, so let me go. Okay, so I just want to briefly cover some of the ground that I did last time, because in a sense, you know, previously on the West Wing, or previously favorite soap series, is always a useful thing to do. So I started off last time by talking about the Celtic Tiger, the Irish economy, which went boom in the early noughties and was doing fantastically well, and then it crashed horribly. And we went from roaring tiger to drowned kitten. We had the IMF come and take us over, and we were one of the pigs, Portugal, Ireland, Greece, and Spain, one of the countries taken over, and our health system was suddenly starved of funding, and we were in a desperately sorry state. So we went through that shock, which was fairly horrendous. But from the ashes of disaster come the roses of success, according to the script of Chitty Chitty Bang Bang, I do believe. And actually, Sláintecare, okay, the new health reform program, because all the politicians decided they would get together, they needed to fix the health system once and for all, because it had been such a disaster and a political football. So they all came together, and the picture in the middle here shows all these politicians of different stripes and of different persuasions coming together and standing there with the Sláintecare report and signing off on it. So that was a great day, and Roisin Shorthall at the front there was the chair of the committee, and I had the privilege of leading the technical team who supported that process. So that was great fun. But then it wasn't all plain sailing, because if you remember from the previous talk and the Swiss Guards down here, it was rather slow initial progress. And I don't know if you remember, but I talked about the problem of being a guard. The problem of being a palace guard is that a key question is, how do you respond to problems when they occur? If you rush quickly towards the problem, you're going to have to fix it. But if you don't do anything, people get mad. So the best strategic option for a guard is to rush slowly towards it. This is what we found the government doing, just rushing slowly. So people couldn't shout at it for not doing anything, not really doing that much. So the key problem there, as we got off, we were a bit slow out of the blocks, despite this fantastic political consensus on this policy. And then, just to remind you, what's in Sláintecare again, because you may have forgotten, I'm sure you knew, but what's in it again? So it's basically a universal healthcare program for Ireland. Ireland is very unusual in having a sort of two-tier system in Western Europe, in not having an entitlement to free GP care, for instance. It's very much out of line. So this was to try and modernize the health system, bring universalism in, so we have entitlements to care for all residents, eliminate or reduce charges to access. We had a key focus on integrated care, providing care at the lowest level of complexity, trying to move it out of the hospital into the community primary social care settings, with all kinds of empowered patient approaches, strong public health approaches, expanded workforce. In terms of the funding, the focus was to really bolster the beverage system. So it's a tax-based system, really bolster that, put in place a transition fund so we could bring lots of new capacity into the system, and controversially take private care out of public hospitals, because we're finding the dual practice nature of private care in public hospitals was being really unhelpful for our waiting lists, which were very long. And then finally, we had an implementation office to drive the reform program. That's a lot of stuff in there. You may not be able to remember all of that, and I won't be testing anybody, but just in case you can't remember all of that, just remember this one thing. Sláinte is what you say is when you lift a glass of Guinness. It's cheers, okay? It's good health, Sláinte. So that's what it means, and basically fixing the system. So that's what it's all about. So really what I'm going to do today, so I've done my quick recap of where we got to last time on my NAO lecture, and I'm going to think a little bit about how shocks change the landscape. Because we had the economic crash, we've now had COVID. How does that change the landscape for reform? What do we do with reform through these times? And then understand some of the troubled and troubling history of Sláintecare through this period. And what are the prospects for it now? What are the options? Where do we go? And focusing in then again on this relationship between shocks and reforms, and hopefully finding some interesting stuff in the middle of that. That's what I'm going to be covering today in the rest of my time, and hopefully that'll then allow us to have some questions. So I'm going to just take a slight detour now, just think about shocks and health system resilience, because this has been an important thing for the Irish health system, is how do we build resilience, and particularly when we had that crash when the Celtic Tiger got stuffed and shot and whatever else. And there are three different elements to thinking about it in traditional thinking about resilience. One is that a shock comes in and you try and absorb it, you try and absorb the resource imbalance, because what happens when a shock comes in is either your supply side is massively hit and you can't respond, or your demand side is suddenly overflowing with all these further needs. You've got to try and balance that out. So one idea is to try and absorb that, to deploy extra resources. The second is, and if you like, if that domino falls over, you try and adapt by making your system more flexible, more efficient, so that you can do more with less. And then if that falls over, you think then in terms of transformation. How do I get my health system to change, to become what it needs to be able to deal with the shock? And that three-part, if you like, that trio of concepts is very much alive and kicking in all the discussions around health system resilience, even today. I was on a webinar the other day, and people were talking through some of these different concepts. But it's not quite good enough just to focus on that. And one of the things that struck me was when the Irish economy had bounced back, the money was flowing again, the shock had gone away, is that actually waiting lists suddenly went through the roof. And we'd had this backlog, and suddenly we couldn't cope with it. It's almost like this pent-up demand, that actually things got much worse when the money rolled back into the system again, and we started to kind of get things going again. Suddenly, we'd had this rationing, we had a failure to invest over the crisis period. We got this massive backlog of care. So what the interesting thing was that the shock produced a long-lasting legacy, even though the shock had gone. And shocks change our health system, and shocks change our society. And even when they've gone, they leave things with us. And we have to pick up pieces. Some of that might be positive, some of that might be negative. And this came through particularly. Actually, this was about a couple of months before I came, did the NAO guest lecture, and I went to February. Sorry, yeah, I went to February, and we went to Portugal. In fact, we went to Lisbon. My wife and I, Debbie. Please have a chat with my wife and my daughter here. My daughter wasn't with us on Lisbon trip, but next time we'll take her there. And we went to Lisbon, and where it was, by the way, plus 90 degrees, rather than minus 15. So that was also a good reason to be there. But I went to a museum called the Lisbon Story Centre. And there it talked about the history of Lisbon. It had the Etruscans and the Romans and the medievalists and this, that, and the other. And then about halfway through, there was an audio visual centre. It was done on a timed basis, so you couldn't get into this. And then, when it came to 12 o'clock, the big doors opened, and I walked in. Okay, and it was just me in this large auditorium, these 3 screens around me. I was like, this is fantastic. And I sat down in the middle, and I was watching this, and all these happy Lisbon people, I don't know what you call it, a Lisbon person, a Lisbonite or something, whatever. They were all happy there, and they were all going around their daily business. In fact, they're going to church. It's a special festival day, and they were selling their wares and all the rest of it. And it was always great. It's very nice. It's a nice timepiece. And then suddenly, in the middle of this audio-visual thing, they had this earthquake, and everything shook, and masonry fell over and started collapsing and falling about. And then you had these massive fires things were set on light, and a fire raged through Lisbon. And then you had a massive tsunami that came through. The total thing was complete devastation. I was sitting there in shock, because I thought I was just coming to see something on a timepiece on how pleasant Lisbon was in the 18th century. And then it sort of settled down, and suddenly a door back at the auditorium opened, and a light went on. Bing! I thought, okay, I better go through there. And I went through there, and then there were more sort of dummies lying around like this, conveying the destruction of this particular tsunami. And then I got to another room where there were sort of dummies standing around a table with blueprints. And actually what they were doing was designing modern Lisbon. And I twigged it, of course, the legacy of this destruction was to create the modern city. Even though it was terrible immediate impact, actually it was utilized by the Lisbon authorities to completely change the architecture of the system. And you can see fine architecture here, amongst others. So it really does present us with an opportunity to make things new because of the changing circumstances. People need to respond. The old potentially can go. And it's this thought that maybe we are maybe even now building legacy that goes a long way into the future by the changes that we make in response to the pandemic. And so that led me to thinking about health system resilience, and as part of a sort of shock cycle. So shocks come and go, you get ready for them, you try and deal with them, you deal with the legacy of them, and they're sort of cyclical. And I think that's an interesting way of thinking about this. And when we bring this back to Sláintecare just now, And then did some work with the Observatory on this whole issue around strengthening health systems resilience, and there's a link to the paper here, and looking at this dynamic aspect. So, and what's interesting is we did a recent systematic review with colleagues, and we looked across high-income countries and the shocks that we've had over the last 20 years. COVID, of course, had lots of studies on that. Economic crisis, natural and man-made disasters, pre-COVID pandemics. And actually, in only a few were people looking at this legacy issue, the sort of recovery and learning legacy. And I think that's one of the most important elements of a shock that we need to be thinking through. We can often get caught up in the management, obviously, because the needs are immediate. We need to think about what are we building, what are we creating, what legacy do we build. And then coming back to Sláintecare, we can see Sláintecare actually as very much a legacy issue from austerity. So it was really produced as a consequence of that. If we hadn't had the shock, we wouldn't have Sláintecare, which is an interesting thing to think about. Okay, so let's see where has Sláintecare gone since its beginnings? It had a plan for universal healthcare, and in this slide, I start to look at the first couple of years of implementation. So on the left side here, we have the original Sláintecare plan, and then on the right side, what happened in terms of implementation. So first of all, removal of hospital inpatient fees. We want to make the system universal. It's not a key gatekeeping place, so we could do it. It's quite low cost. No, didn't happen. Halving of the drug payment scheme thresholds for single-headed households, to try and help single-headed households. Yeah, we were trying to lower the rate at which they get paid back for drug expenditure. Didn't really happen. There was a general reduction by around 20 euros, which wasn't a lot. 400,000 more people with free GP care. 5,000. Reinstatement of dental benefits for people with dental costs. No. Reduction of prescription item charge to half a euro per person. Lowering prescription item charge by half a euro. So all these big achievements already we were kind of missing. Already we seem to be watering it down, and we didn't seem to be going anywhere. And actually, we did a check through the subsequent policy documents the government developed after Sláintecare for those 2 years, and we played a game of where's Wally? Do you say where's Waldo?
Yeah. Where's
Waldo? Okay. So we played a game of where's Waldo, and we decided to have a look through the policy documents and see, does anybody mention entitlement? And this policy document, no. This policy document, no. 3, the policy documents, 1 mentioned it once. So there's a bit of concern here. Okay, we were signing up to universal healthcare, but what actually are we getting here? So we were worried that having got into a brilliant state with the Sláintecare policy, we were starting to evolve in an unhelpful way. Too many, too much is there. Never mind. So it wasn't great. So, and then heading into 2020 then, and we've been doing some interviews, and I'm going to be quoting from some interviews recently. Doing some interviews heading into 2020, and the part of the message was the health system was doing damage to the state's reputation because it was spending so much and driving the state to have a debt level it didn't want to be associated. So in the early part of 2020, it's all about constraining finances. We can't afford this. We can't afford that. We can't. And this led to Roisin Shorehall, whose happy face you saw, holding the Sláintecare report on the first slide, to say Sláintecare has been relegated to some time in the future. So it's looking pretty grim, looking like this whole thing was being squeezed and the whole thing was being stopped. But then the pandemic and how things changed. And one analyst who we interviewed said, COVID gave us rockets. Suddenly, from nothing, we had 20% extra money in the health system in 2021. A lot of it for COVID care and protection, and suddenly everybody, who needs COVID care was getting it for free, testing and tracing for free. Anything to do with COVID, you get it for free. So all the access charges that were in place dropped. But more importantly, the government was actually funding Sláintecare, as it should have been previously. All the capacity elements of the Sláintecare program, the government was chucking money at. So we can see here on the slide, we've got additional beds, we've got extra community services, we've got access to care fund, that's to do with waiting list reduction. And we've got models of care, so that's to do with integrated care and thinking about how do we move care out of hospitals into community settings. And suddenly, government's chucking money at this because actually our economy wasn't doing too badly. So that kind of helped. We had lower borrowing rates, lower debt to GDP ratio than we had previous crisis, and the government had been wise enough to stick a rainy day fund aside. So suddenly, money was coming in like no one's business. Money was no object because the health system was worth it. So chucking money at the problem. And the message was, whatever you need, ask for it. Whatever you need. Total. So, and there's this idea, and we got this from two different managers that we're talking about, quite high level senior managers were saying, suddenly people understood the value of the health system from an economic, a critical economic asset. So suddenly that shift, and that's all to do with the shock. So suddenly the shock had changed how people see the health system and this massive funneling of resources, not just into COVID care, which was understandable, but actually into making the system work better, which is what we need. Now, it's quite useful also just to step back a bit and to understand the politics, because, you know, where did this Damascus Road conversion come from? Was it all to do with people just seeing that COVID is a big problem? And it's worth taking a step back and thinking about some of the politics that was going on around this at the same time. So it was all happening in Ireland. I'll tell you, it was all happening. So we had elections in February 2020. And here are the Rogues Gallery, if you like, the three party leaders, Michael Martin, Mary Lou McDonald, and Leo Varadkar. And coming into this election, housing and health were the big ticket issues. So it's interesting, the public weren't fooled by this, oh yeah, we're doing Sláintecare, oh yeah, we're doing Sláintecare. Nothing's actually going on. The public weren't fooled by that. It's like, oh, come on, where's the beef? Where's the beef? Come on, let's get on with it. So they were making a big noise. And actually, I think it surprised all the politicians, including Mary Lou McDonald, the leader of Sinn Féin, that Mary Lou McDonald and Sinn Féin actually got the highest number of votes of any party. And Sinn Féin themselves were surprised. They hadn't really fielded enough candidates. And had they fielded more, they might have been in a position to form a government. But as it was, they got the largest number of votes, they got 535,000, but they only got 37 seats. So Fianna Fáil got one more seat. Fianna Fáil had also been in opposition, and Fine Gael had been the previous minority government, actually got then 35 seats. So we had this three-way split. So another interesting dynamic of how was this going to work out. And so Fianna Fáil and Fine Gael decided they didn't want Sinn Féin in power, because Fianna Fáil and Fine Gael actually, they're quite similar in their policies. Although they've been the traditional government and opposition, and they've swapped throughout the 20th century, their politics is fairly similar, sort of centre-right, centre a bit right now and again. Fine Gael slightly more right, but not much in it. Whereas Sinn Féin will be fairly radical Republican left. So they decided they would do the unthinkable. They would make friends with their erstwhile enemies, and they would form a government. But even then, they didn't have enough votes to get it over the line, because they only had 73 seats together, and they needed 80 seats. So they needed to reach out to somebody else. So they went down to the minor parties. Okay, so they started looking and saying, okay, who do we get? Who do we get? Who do we get? And then you've got the sort of definitive left-wing parties of Labour and Social Democrats, and the Greens, who look left-wing, except when they get in government and when they become very conservative. So suddenly they shed all their left-wing credentials, and so they grabbed the Greens, and that got them over the line. But one thing I think that was going on is once you got that formation in there, which looked like it could be sort of pretty centrist, they realised that they needed to undermine Sinn Féin's political appeal. and they needed to shove money at the health system, because that's what Sinn Féin would have done. So we need to fix the health system. Now is a great time to do it. So I think it's quite politically expedient for them to do that. So I think that was probably what was going on, as well as seeing the attitude. So the policies, I think, came together around that as well. And actually the government did pretty well at this time. And one of the, as it says, the nice thing about COVID is actually the health service is more popular than it used to be. Suddenly everyone's appreciating it, and I think that is not a trivial achievement. And we see here a chart here looking at public reaction to what the government is doing. And actually, question is, do you think the reaction of the government to the current coronavirus outbreak is appropriate, too extreme or not sufficient? And actually pretty good scores here. Public were pretty well done. Good job, good job. Health sector's doing okay. We're not being overrun, which we weren't. A bit, touch and go moments were pretty good. The only moments where there was a bit of public dissatisfaction is when the politicians, the right-wing politicians, decided, we've had enough of the science. Let's go it alone. And actually that then backfired, and we had very high rates. So they shut up quickly, apologise humbly, and let the scientists get on with it. But generally things going pretty well here, even despite all the obvious all the obvious tragedies of the COVID era. And so for Sláintecare, it looked like everything was coming up roses until in September 2020, disaster happened. And the head of Sláintecare, Laura McGahey, resigns because of significant challenges in tackling wait lists. Some of the key issues just were not being addressed. And then Tom Keane, the chair of the Oversight Committee, also resigns. So suddenly everybody's resigning because despite all this money going in, some of the critical issues around waiting lists, around entitlement to care, some of the stuff around changing how things were structured weren't happening. There was resistance. And so actually, even in this funneling of money, there was money for capacity expansion, but maybe not some of the hard choices actually about making a single, unified, well-organized system that allows people to access care when they need it, not according to their ability to pay. So there was resistance going on there. And then the Department of Health took the interesting decision that rather than actually appoint someone into those positions instead, what they would do is they would absorb the implementation of this into the ministry and scatter the responsibilities throughout, which does look a little bit like the kiss of death. So and a lot of the politicians saw this hopping up and down, particularly the ones at the start had been holding up the report, and they got quite emboldened. What's going on? What's going on? What's going on? So there's quite a lot of heated kerfuffle around all this. And so that's kind of really one of the things of where we are right now. So we can see 4 distinct ages of Sláintecare. We can see spring chicken, we can see rubber chicken, we can see steroid chicken, and we can see headless chicken. So, and the question is, is this something that's going to repeat? Are we going to, where are we now? Where do we go? What is the story with this? So, what's going to happen? So, multiple choice quiz. So, do we get looking like Sláintecare, looming austerity, looping reorganisation, or losing public support? These are the key dangers. Now, I'm sort of trying to be healthy, That's the best way to do it. I've tried to reduce my meat intake. Okay, and I sometimes go to the supermarket and I get stuff which says no chicken burgers. Okay, I love that, no chicken burgers. Okay, and here we go. I have a picture of one now. So if you haven't had your sandwich already, you're feeling a bit peckish now. So no chicken burgers. And my worry about Sláintecare is that we're going to get no Sláintecare. We're going to get something that actually we're pretending to do it, like the rubber chicken. Well, we're not really going to do it. We're just pretending. So the second worry is the kind of looming austerity. And one of the interviews talked about Cinderella health system financing. Cinderella whisked from the kitchen into the ball. She's fated. The Minister of Finance dances with her. She's, popular, and her life is going to change, or not, or is it going to go back again to the kitchen, and the health system is going to get relegated again? And of course, now we have issues around supply chains, fuel costs, war in Ukraine. It looks like an economic crisis is coming just when we need the health system to recover. So what's going to happen? So looming austerity. Looping reorganisation. This is something that the Irish government loves to do. One of the highest profile health fights in 2020 was not about entitlement to care. It was about, we need to get reorganising again. It's part of Sláintecare. It's a good thing to do. And it's one of the parts of Sláintecare we have a little bit, I just feel like this is not the best fit, because I think it could hold us up. The argument is if you reorganise and restructure, then it allows you to look at integrated care better, which allows you to have a more better capacity in the system to cope with when you make care free, so we can deliver care. But that's a bit of a logic sequence. And my worry is that actually reorganisation tends to get stuck and go badly and take longer than you think, and then you have to sort it out. So my worry is it's a way of delaying. And my colleague Sarah Barry, who I quote here, looked at 5 different phases of reorganisation between 1998 and 2020 in Ireland, 5 different phases of decentralisation, centralisation. And in all cases, she highlights an absence of unified purpose, of proper change management and implementation planning, leading to weak or inconsistent implementation. And yet we keep doing it. We keep reorganising because it gives us something to do, which is a little bit like the definition of insanity. So I've put at the bottom. So my worry is that is a red herring. Now, I have colleagues who probably might argue with that, but I worry because I think it can pull us away from actually what's important, delivering care when we need it without key access point barriers. And then losing public support for Sláintecare. I think this is the real kryptonite problem. My worry is after 5 years, we haven't really got very far, and cynicism and disillusion will set in because people haven't seen the wins. Where's the beef here? And I note the creeping enrolment in private insurance. We've had quite high private insurance cover. Then what you see over here actually is from the crisis onwards, things drop because it became unaffordable. But then what's happened since then is it's crept back up, and that's partly to do with the previous Minister of Health, who tried to introduce compulsory private insurance and failed. But what he did as a sop to the private sector, the private insurance industry, he brought in lifetime community rating. And basically what that means is if you haven't got private insurance, you haven't enrolled in private insurance by the time you're 35, you will be penalized for every year that you haven't got it. So if you try and then join when you're 50, you will pay 15 years of penalties. Okay, the point is to try and shore up the private insurance system, even though that's part of the 2-tier thing. So my worry is that going on in the background and people's lack of confidence with Sláintecare means that we can see this creeping expansion of enrollment in private insurance, even during COVID, which is interesting because a lot of the capacity was shut down then. So that's one of my key worries, is that even if people want to support Sláintecare, they're going to feel divided because they've got this private insurance faster access. I'll skip that slide. It's kicking on. Okay, but I think there's probably a cause to be hopeful. I think there's some suggestions within some recent discussions and recent initiatives that the government may be trying to find its mojo again. And this quote here is from Minister Stephen Donnelly, the 21st of May, 2022, and I actually can't read it because of the slide is organized. I'll have to read it off my notes. Whether that's worked there. Here, actually, Minister Stephen Donnelly says, for far too long, access to care and health outcomes have been adversely impacted by ability to pay. I believe health services should be affordable, free at the point of delivery. Only a couple of weeks ago. Great. The minister gets it again. Hooray. Maybe Sláintecare isn't going to be, it's not going to be headless chickens anymore. It's not going to be rubber chickens, whatever else. And then we look at what they're doing. Free access to inpatient day case care for children, cutting the drug payment scheme, expand free GP care to 6 and 7-year-olds, free contraception to women aged between 17 and 25, abolish inpatient day case charges. Whoa, is the minister getting it? Let's look at that more closely. Free access to inpatient day case care. Expand free GP care. Free contraception to women. Abolish inpatient and day case charges in 2023. So again, we see this reluctance. And actually, the last one, abolish inpatient and day case charges in 2023, was meant to be done in year 1 of Sláintecare at a cost of it's not big bucks, and yet here we are already putting it. So my worry is that, you know, if we carry on at this pace, where will we be? I mean, I have here a picture of me, okay? I put it into one of those apps, change my face. This is me at 70, okay? Having had, I think, one too many Guinnesses by the looks of my face here. And I'm worried that I'm going to get 70 when I have to retire. Okay, when I have to retire. And my worry is that I'm going to be retiring before we get there. If this is the pace we go at. This is very, very slow. And Sláintecare is meant to be a 10-year program. So if we get it by the time I retire, it's a 20-year program. Anyway, so final reflections, I'll start to come into land now. I think maybe I kind of need to take a chill pill. Maybe we just need to accept that big reforms take a long time. They're not linear, they're complex, they have to engage with a complex adaptive system. There's going to be things that work for you, things that work against you. And so maybe I like the cartoon says. Maybe I just need to stop worrying about stuff that is or isn't going to happen. So that's kind of one reflection. Another one is we need to come back to thinking about this shock again. Sorry, this issue again around shocks and how we respond to them, because they leave legacies for our health systems. And we will leave a legacy whether we like it or whether we don't like it. So we might as well own that. And what we are doing now in COVID will create a way. It's almost like thinking about the path dependency issue. We set things into bit for how they will be, how they will roll out for many years. So what legacies are we creating in Ireland and Canada, in other countries? COVID made the case for massive investment in the health sector in Ireland and in other countries. But the key question is, what's going to happen to Cinderella? Can it be sustained? Will we be able to honour our health professionals who need help, who are exhausted, morale is low? We need to help them. We need to deal with the backlog, which is there. And it's interesting, isn't it? Every shock seems to produce, every big shock seems to produce quite a pronounced backlog of care. That's going to need a lot of resources to get us through that over the next couple of years. And the last thing we need is the austerity kind of prism to come back to us, which will, you know, probably finish off our workforce. And second, lots of fun reflection. Sláintecare, born out of a shock, reinvigorated by a shock, but actually required for a shock. You know, if you've got the capacity in there, you can deal with it. If you've got a well-engaged and supported workforce, you can deal with the shock. If you've got better access to care for people and fewer waiting lists, you can deal better with the shock. You know, a good performing health system is so important. So I think reforms and shocks can go hand in hand if we're careful, if we're intentional, if we're courageous and prepared to put resources behind it. And I kind of reflect on the, if you like, on the resilience of Sláintecare. It's gone through a lot. It's still standing. It's still going. people are still seeing its merit. So I'm hoping that I'll be able to come back in maybe 5 years' time and report back on its conversation. Thank you. Thanks very much.